Labs and SBAR, and we're also going to discuss vital signs. Vital signs change with aging. We have temperature, uh, heat loss might lead to hypothermia in the elderly. They have a lower metabolic rate that can result in hypothermia. Their respiratory rate might vary with decreases in vital capacity, and systolic and diastolic blood pressures might rise with hardening of the arteries. So let's talk about temperature. We know that temperature can be affected by the environment, illness, increased metabolic rate, activity, diaphoresis, etc. There's several types of thermometers available for use. Some of them we talk about would be the glass thermometer. We should never use glass thermometers in an unconscious, confused, or agitated client because these are usually used orally. We can use them axillary. We can also use them rectally, but there's usually a specified thermometer for rectal temperatures. We have electronic thermometers such as the tympanic thermometer, which will approximate the core body temperature. We have the temporal artery skin thermometer. This is actually more accurate if it's used correctly. And we have disposable thermometers, which are designed for single use. We know that the normal body temperature is 97.5 to 99.5. And temperature measurements will vary depending on the site that is used. Rectal temperatures are going to be about 1 degree Fahrenheit higher than oral temperatures. Axillary temperatures are about 1 degree Fahrenheit lower than oral temperatures. And tympanic membrane measurement will approximate that core body temperature. However, when you're taking the temperature, we don't say, for example, we had a rectal temp that was 99.3. We would not say the temp was 100.3. We're just going to say the temp was 99.3 rectal. Or if it was axillary, say we got a 98.5 temperature, we would not say that we had a 99.5. We would just say 98.5 axillary. We do consider a client to be febrile if they have a temperature of 100.5 degrees Fahrenheit or higher. So in other words, we know 99.5 might be a normal temperature for some clients. So we do not say that they actually have a fever until we hit 100.5 degrees. Rectal, axillary, or tympanic temperatures are preferred for infants, small children, or clients that are unconscious or uncooperative. We have begun limiting rectal temperatures for the simple fact that we can easily perforate or poke a hole through some of those rectal tissues. So we don't do very many rectal temperatures anymore. Nursing interventions to reduce fever. We increase their fluid intake, lower the room temperature, increase the rate of circulating air, remove excessive clothing or bed covers, control or reduce the amount of body activity, provide a sponge bath or a cooling blanket or what we call the tepid bath where it's more of a room temperature, or administer antipyretics such as aspirin or acetaminophen. The heart rate is affected by fever, pain, fluid volume, hypoxia, anxiety, exercise, and cardiac disease. This picture indicates some of the common pulse points. The radial artery is located in the wrist at the base of the thumb. The temporal artery is just in front of the ear. The carotid artery is on the front side of the neck. If you're palpating carotid artery, you never palpate both sides at the same time because you're interrupting blood flow to the brain. The femoral artery is located in the groin. The apical pulse would be located over the apex of the heart. The popliteal pulse is located behind the knee. And the pedal pulse of the posterior tibial artery is on the inside of the ankle behind the malleolus, or the ankle itself. The dorsalis pedis is located on top of the foot. Realize that the pulse rate can vary from one site to another. Characteristics of the pulse rate will include the rate, rhythm, or regularity of the intervals, the volume or force of the heartbeat, and tension or resistance to pressure. Medications can be prescribed to speed up the pulse when it's too slow or to slow it down when it's too fast. A pulse deficit is measured by nurses using one watch that's visible to both nurses when they're counting the apical radial pulse. You begin and end counting at the same time. One nurse will count the radial pulse while the other counts the apical pulse. The radial pulse will be subtracted from the apical pulse, and this equals the pulse deficit. When we're describing pulse characteristics, we're talking about the rate, rhythm, and volume. An arrhythmia is going to be a period of a normal rhythm that's broken by periods of irregularity or skipped beats. The average pulse rate in an adult is 72 beats per minute. Tachycardia is defined as a pulse that's greater than 100. Bradycardia is defined as a slow pulse, so it's fewer than 60 beats per minute. And again, the pulse deficit is the difference between the apical and radial pulses. The strength of the pulse, if it's weak and regular, we have even beats but a poor force. So we would describe that as 1+. Strong and regular are even beats with a moderate force, or 2+. And this is where most of our strength of pulses are going to be, is at 2+. Full and bounding will be even beats with a strong force, or 3+. It might be feeble, which is barely palpable. It can be irregular, so we have both strong or weak beats that occur within 1 minute, or maybe it skips a beat. Thready indicates that it's weak, and it may also be irregular. And absent is no pulse is palpable, and we cannot hear a heartbeat on auscultation. Our respiratory rate is going to be affected by the same things that affect the heart rate, in addition to lung infection and disease. We count the respirations when the client is unaware of what you're doing. For example, we continue holding the wrist after obtaining the pulse, and then we count the respirations. The client's respiratory rate can be altered if he or she knows that you're counting the respirations. So that's why we don't tell them what we're doing. Respiration should be counted for 30 seconds and then multiplied by 2. A normal rate for a healthy adult is 12 to 20 breaths per minute. In the case of a very ill client or one that has irregular respirations, we would count for a full minute. Increased levels of carbon dioxide or low levels of oxygen in the blood can cause an increase in the respiratory rate. A change in the respiratory rate can indicate a change in the client's condition, but it is always considered along with the other vital signs and assessment data. Many of the factors that affect the pulse rate also affect that respiratory rate because the heart and lungs are closely connected in providing oxygen to sustain life. The breathing rate increases about 4 breaths for every degree Fahrenheit or every half degree Celsius increase in the temperature. So let's talk about respiratory patterns. These are some of your definitions. Eupnea is a normal, relaxed breathing pattern. Dyspnea is difficult and labored breathing. Tachypnea is increased or rapid breathing. Bradyapnea is slow and shallow breathing. Hyperventilation is breathing where we have an increase in the rate and depth of the breath. Cheyne-Stokes respirations, we have dyspnea followed by a short period of apnea. Kussmaul's respirations, we have an increased rate and depth with panting and then a long grunting exhalation. Biot's respirations, we have a shallow respiration for 2 to 3 breaths with a period of variable apnea. Apnea means we have no breathing. Now let's describe some of the lung sounds we might hear. Crackles are an abnormal, non-musical sound heard on auscultation of the lungs during inspiration. This might sound like rubbing hair between your fingers. Rhonchi is a continuous dry, rattling sound heard on auscultation of the lungs caused by partial obstruction. It may sound like really loud, significant crackles, or it may even sound like more of a snoring. However, stertor is that snoring sound that's produced when a client is unable to cough up secretions from the trachea or the bronchi. Stridor is going to be more of a crowing sound heard on inspiration, and it's caused by obstruction of the upper air passages. This occurs in conditions like croup or laryngitis. It sounds kind of like this, as the client is trying to inhale air through a very, very narrowed or obstructed airway. And a wheeze is kind of a musical or whistling sound as air is forced past a partial obstruction or narrowed airways. Assessment of the respiratory rate and pattern have to be analyzed together with other data, such as their breath sounds and arterial oxygen saturation, in order to determine a client's specific problem. A pulse oximeter is a machine that measures oxygen in the blood. It measures oxygen saturation by determining the percentage of hemoglobin that is bound with oxygen. We determine this by using a sensor or a probe that's attached to an area of the client's body, and then we pass infrared and red light that reaches the capillary bed. Our oxygen saturations can be affected by temperature of the fingers, some nail polishes, movement of the fingers, or irregular heartbeat. There's different types of probes that we can use. We do have the finger probes, which is the most common. We have toe clip-on probes. We also have adhesive sensors that can be applied to the nose or forehead or even to an infant's foot. We also have a clip-on probe that's available for use on an earlobe. Blood pressure. This is affected by cardiac output, client's posture, muscle activity, and respiratory action. It increases with increases in our circulating blood volume. So if we have more fluid in our blood vessels, then our blood pressure increases. If that blood volume decreases beyond the vascular bed's ability to compensate, that blood pressure may also decrease, often caused from dehydration or hemorrhage. Vasoconstriction and vasodilation will alter the blood pressure, and this helps compensate for changes in that circulating volume. A systolic pressure greater than 140 millimeters of mercury and a diastolic pressure greater than 90 millimeters of mercury are regarded as being outside the normal range and is indicative of hypertension. Pre-hypertension, we have a systolic pressure between 120 and 139 millimeters of mercury and a diastolic pressure between 80 and 89 millimeters of mercury. If a client suffers prolonged hypertension, it can cause damage to the brain, the kidneys, the heart, and the retinas. It also increases the fragility of blood vessels. The average blood pressure in a healthy young adult is 120 over 70 millimeters of mercury, with 120 being the systolic pressure and 70 being the diastolic pressure. Things that can increase the blood pressure: anxiety, fear, stress, and of course there's several different health disease processes. Make sure that you take a client's blood pressure in a quiet room with a relaxed environment. Make sure that the client has been sitting for at least 5 minutes prior to taking the blood pressure. Make sure that the blood pressure cuff is at the level of the heart. We don't want it elevated. We don't want it laying down past the heart level. Make sure that the client's feet are flat on the floor. All of these things are going to help obtain an accurate blood pressure. If you obtain a really off reading, whether it's really high or really low, sometimes we just wait about 10 or 15 minutes and then retake it, making sure that you're following all of those rules. The client should not talk, the nurse should not talk, making sure feet are flat on the floor, making sure they're sitting upright, arm is at, or the blood pressure cuff is at the heart level, and feet are flat on the floor. All of those things are going to help assure that we have obtained the most accurate reading possible. The difference in the systolic and diastolic pressures is what we call the pulse pressure. Pain is also considered a vital sign, and the assessment needs to include the location, the intensity of the pain, the character of the pain. Is it sharp? Is it stabbing? Is it throbbing? Is it burning? Etc. How often do they have that pain? So what's the frequency? Is it continuous or does it come and go? And how long has this been going on? We try to use a standardized pain scale for assessment, preferably the numerical scale. Nurses like to have those measurements because those measurements will help us indicate if things are maintaining or deteriorating, or maybe they're worsening or getting better. Pain levels are going to be assessed and recorded with the other vital signs. Again, to describe it, Is it a slight pain, dull, throbbing, gnawing, faint, burning, sharp, acute? Is it chronic, excruciating, intense, stabbing, spasmodic, or sudden? Is it cramping or stinging, shooting, darting, colicky? Is it continuous, persistent, or transient? Does it stay in one side or does it radiate somewhere else? The pain can also be described by location: the right side, the left side, the posterior or anterior. So let's move on to some of the labs. In your resources in Blackboard, you're going to find these lab levels, the PN KCKCC lab reference ranges. These are the labs that you need to be familiar with per the PN NCLEX test plan that's found in the NCSBN website. So let's look at the complete blood cell count, or a CBC. This is going to evaluate numerous conditions that involve the red blood cells, the white blood cells, and the platelets, such as anemia or other blood disorders. It can also indicate inflammation, infection, or a response to medications or treatments. And it might be part of a screening for a physical examination or a preoperative procedure. Glucose levels assist in the diagnoses of diabetes, hypoglycemia, or insulinomas. They can evaluate disorders of carbohydrate metabolism, excuse me. They can also help determine insulin requirements. They can be done as a fasting blood sugar, meaning without food or drink for about 8 to 12 hours. However, they may be able to have some water. It might be postprandial, which means after eating. Might be 2 hours postprandial, or random. The glycosylated hemoglobin, or hemoglobin A1C, will monitor treatment in individuals with diabetes by evaluating their long-term glycemic control. In other words, how well have they been controlling their blood sugar? And it provides an average plasma glucose for approximately the previous 120 days. In other words, they cannot lie to you. Well, they can lie to you as to how well they've been controlling their sugars, but this is going to confirm whether they've been truthful or not. Communication between healthcare team members is vital to communicate client information to help ensure continuity of care. It's necessary at shift change with handoff reports, transfers to different units or facilities, discharges to outpatient or in-home treatments, etc. It can be from nurse to nurse, doctor to doctor, nurse to doctor, etc. The SBAR is a template that's used to provide consistent communication between members of the healthcare team. Although the templates may vary slightly, the formatted communication technique does help minimize omissions in this transfer of information. We might have the SBAR, we might have SBAR, or we might have SBAR with just one R. I is going to be the introduction. This is where you identify yourself, where you're calling from, the client's age, their name, their gender. S is the situation. I'm calling because I have observed major changes. I have measured the following values, such as vital signs, drain amounts, etc. I have the following results to report. Basically, it's telling why you're communicating or the problems you've observed, and you're reporting the client's current condition and any interventions that may have been done or medications that have been given. B is background. This includes the client's diagnosis, their admission date or postoperative date, procedures or treatments that might have been done, previous significant illnesses, and allergies. A is your assessment. What have you assessed, such as vital signs and recent lab results? If you feel the situation is emergent, you need to be sure you speak up. R, this is your recommendation. You're going to request advice. What would you like me to do? Or request specific interventions. For example, let's say their temperature is elevated. Could I have an order for acetaminophen to help with the temperature? The second R is going to be the read back or your repetition of any prescriptions received or clarification of communications. So let's look at this SBAR example. Our client is a 53-year-old farmer who developed severe back pain while feeding his livestock. The pain radiates down the back of his left leg and he's unable to stand. He has a previous history of back pain with the diagnosis of lumbar spondylosis, a history of a fractured tibia fibula from an accident that continues to cause pain with prolonged standing. He also has a history of psoriasis, which is not well controlled. He is a smoker. His medications include betamethasone, ointment, calcipotriene, and hydrocodone/codeine for a TID for pain. Currently, he does have intractable pain of 9 out of 10. His blood pressure is 135/95. His heart rate is 95. It's regular. He is unable to lie down for examination, and his urine shows a trace of protein. So let's put this in an SBAR format. I would say for I am Deb Taylor from the Urgent Care Center calling about Mr. XYZ, a 53-year-old male. S. The client reports severe back pain while feeding livestock today with pain radiating down the back of the left lower extremity and he's unable to stand. B. He has a history of lumbar spondylosis and takes codeine TID for pain. A. Pain is reported at 9 out of 10. Blood pressure is 135/95, and his heart rate is 95 and regular. He is unable to lie down for examination. R. My recommendation. I feel a CBC and ESR may be indicated, and the client may benefit from additional pain medications or a muscle relaxant. And then my second R, I would repeat any of the prescriptions that the healthcare provider gave me. Let's do one more example. A 48-year-old man is brought into the emergency department following a fall at his home. He had become intoxicated and fell down several steps, and although still intoxicated, is reporting abdominal pain. His vital signs are within normal limits. Examination reveals a large bruise to the left flank, a distended abdomen, and mild, diffuse abdominal tenderness. His bowel sounds are active ×4. Excuse me. He also has bilateral lower extremity edema. The client has a history of alcohol abuse. And we're saying that this man is in the emergency department, so Of course, the healthcare provider would know who you are. I have a 48-year-old male in exam room 5. S. The client fell at home after drinking of alcohol and is now reporting abdominal pain. B. The background. The client has a history of alcohol abuse. A. Your assessment. There's a large bruise to the left flank, abdominal distension, and mildly diffuse tenderness. Vital signs are currently within normal limits and bowel sounds are active ×4. I feel there may be a potential internal bleed going on. R. The recommendations. I feel you need to see this client ASAP and wonder if you would like to order a CBC and abdominal ultrasound as soon as possible. And the second R, again, repetition of any orders that have been received.